So today, to help us discuss the National TB Prevalence Survey that was done in 2015-2016 and a bit of TB program is Elizabeth Mweni. Elizabeth Mweni is a TB coordinator in Nairobi County. She is the one who is leading the fight against TB in Nairobi County. She has extensive experience in both clinical management and TB programming. Most of the healthcare workers managing TB in this county have gone through her hands in terms of her training them. So it is a great privilege for me to invite Elizabeth Mweni to take us through today's webinar. Karibu Mweni.
Thank you, Dr. Tabitha. I hope everyone can see my screen.
Yes, we can, Mweni. Please go ahead.
Okay, thank you very much. And I'm happy to be here. I'm going to take the team through the Kenya TB Prevalence Survey and TB programming in Kenya and how we do things around here. So welcome for this session. So we'll start with the Kenya Prevalence Survey. And just to start, this is how our TB cases were from 1992 to 2015, when we started having the prevalence survey. As you can see, we had a peak in 2006. Then the TB cases started going down. WHO saw that Kenya was to the verge of ending TB because the prevalence survey that WHO estimated was around 233 per 100,000 based on the reduced number of cases as the year from 2009 to 2015. So the prevalence survey took place in 2015 and 2016, and we are going to see what happened during that period. So just to put a recap on TB in Kenya, TB epidemic usually affect the young, productive age group between 15 to 34 years who are economically active team. And in 2015, Kenya reported up to around 81,518 TB cases, which was very low, as you saw the previous slide. And this was estimated by WHO. Our prevalence survey was 233 per 100,000 TB cases. So Kenya was able to detect about 80% of the TB cases at that time. So what were some of the key findings on the survey that was done and released in 2017? The estimate, as you can see here, 2015 WHO estimate was 233 per 100,000 population, but the survey that was done, it showed that we have more TB than what WHO was estimating because our prevalence turned out to be 426 per 100,000 population. So this translates to approximately 138,105 TB incident cases per year. So we were missing a lot of TB cases by that time. And this is where we are currently based on our prevalence survey in 2016. So it showed that we have more TB than what WHO was estimating in 2015. The survey also showed that TB was more among the male gender, even twice higher the male gender. You can see the blue dotted bar is the one that shows the prevalence of TB among the men, while the ladies, the prevalence was lower. And as you can see, male had higher disease burden of even up to 809 versus female 359 per 100,000. So this survey also showed we are missing a lot of TB cases among the men, and there was significant also TB among women of the age of 55 years and above. Also, the survey showed that TB is more prevalent in the urban setting than rural setting. As per the red bar, it showed that most of the TB cases were more prevalent in the urban setting, unlike the rural setting that we have in Kenya. So when we compare the HIV positivity and negative, the survey showed that 83% of TB cases were HIV negative. This suggests that intervention to control TB among people living with HIV was very successful, and large burden of TB is now exist among people who are not affected by HIV. So how can we ensure that we're able to get these people and able also to support them so that we don't miss the cases among men and also HIV negative community? So this is a very important slide because it shows some of the symptoms that were there during the prevalence survey. And as you can see, the cough, cases of cough more than 2 weeks, there were around 48% of people who had a cough above 2 weeks. Night sweat alone, 28% of the cases had a night sweat alone, fever alone. But I want to look at the red area that is highlighted. Client who came with weight loss or fever or night sweat or cough for more than 2 weeks was at 59%. And the last one, any coughing or fever, weight loss or night sweat or fatigue or other symptoms or shortness of the breath, that at least one of these, you can see it was the highest. 74% of the clients that were subjected in this prevalence survey had any cough of any duration and fever, and it was not anything more than 2 weeks. So 74% of our clients had the symptoms that were even less than 2 weeks that came to the survey. So if other TB-related symptoms are also included in the sputum eligibility criteria, the prevalent cases missed by symptom screening will be reduced. So when we look at the health-seeking behavior of the 3 of 5 positive TB clients that were diagnosed during the prevalence survey, 74% of them, those who were diagnosed to have TB that time, they had symptoms of TB, either a cough, fever, night sweat, all the signs and symptoms of TB, and 26% had no symptoms for TB. So this is an area that we are looking at, and we might even miss. You can see these are 26% of the clients that are missed, those who come without symptoms, and they could be missed in our facilities. So among those 74 who had symptoms that were not severe were 25%, because these were the clients that were not coming. This survey was done at our homes and the community and not facility. You can see these are the ones, if the symptoms are not severe, we are also missing those cases. 33% of them, they were able to go to health facilities, and only 15 of them were diagnosed to have TB. So there's a percentage that was missed, that had TB but was missed, and they came to our health facilities. Then we have a 42% who did not seek any treatment because of other reasons. And these are things and areas that we need to look at. Out of all those, we have loopholes of missing TB cases, both those who never had signs and symptoms, and those who had signs and symptoms and never came to facilities, and those who never cared about their symptoms. So where are these missing TB cases? Very important to note, there are people in the community with the non-severe TB symptoms, and they are not coming to facilities. They are staying in the community, transmitting TB. We have these people at the workplace, home and clinic, presumed to have TB and are not screened for TB. Then the red one, the last one, people are coming to our facilities seeking treatment. They are coming to seek, they're having TB symptoms, and they are not being diagnosed at facility level, because you can see 33% of those who had TB symptoms from the previous slide, they came to the facility, and only 15 of them were diagnosed to have TB. There was a higher percentage that was missed since they came to the facility and they were not diagnosed to have TB. So in conclusion, this survey, what did it find? And this is a summary for a prevalence survey that we had in 2016. The burden of TB in Kenya is higher than what WHO was approximating at 233 per 100,000. Our prevalence survey is at 426 per 100,000. So we are missing 40% of the cases are not being diagnosed. Then number 2, men are more affected by TB than women, okay? 8 or 9 per 100,000, that came out from the prevalence survey. TB is more in the urban setting than rural setting. Then most of the TB clients during survey, 83% of them were HIV negative, and there was significant number of women above 65 years old that were found to have TB. When we come to screening and testing, the survey showed that the current practice that we had by then of TB symptom screening misses TB cases, and chest X-ray that time emerged as a good screening tool for TB. We were using microscopy a lot to diagnose TB before 2015, and you can see microscopy misses some cases because that time our patient was subjected to gene expert test. So it showed that microscopy misses cases, and gene expert was a more reliable test for TB. When we look at the health-seeking behavior based on the last slide that I showed, we found that people have symptoms in the community and they are not seeking care to the facility. People also with TB symptoms are seeking care, either the private or public in our facilities. Then we have 3/4 of people with TB symptom who seek care do not get diagnosed. They are coming to our facilities, but we are missing diagnosis of these clients that are coming to our facilities. Then 1/4 of those found to have TB did not report any signs and symptoms of TB. So this is the summary that came from the survey that was done in Kenya 2015-2016. So what are some of the things that we need to do to find the 40% missing TB cases? And this one was divided into 3. On matters TB screening and diagnosis, what do we need to do? Because we are missing TB cases. We need to expand symptom lists for TB screening beyond the normal cardinal signs that we are used to. We need to look at cough of any duration, and we need to look at the night sweat, weight loss, fatigue, fever, and shortness of the breath, because these were very critical during the survey. We also need to screen all persons with respiratory symptoms seeking care in health facilities for TB. Yeah, these are the patients that are coming to us. They have signs and symptoms. We need to screen them for TB as they come to our facility. Then make diagnostic accessible where patients seek care. We need to expand our chest X-ray. It showed that it was a good screening tool for the client who had presumptive TB, and make gene expert our first diagnostic for all presumptive TB cases. When we look at those patients that came to the facilities, they showed that they visited both the public and the private facilities. So we need to have a good partnership. We need to have a good PPM sector partnership with our private sector. We need to engage the private sector in screening of TB and treatment, even the informal private sector, the small facilities, the small lab, to ensure that we don't miss these cases of TB that are coming. On matters community-based action, what needs to be done? We need to develop and implement targeted approaches for TB screening and active case finding among young men and elderly. How can we ensure we have some innovation of getting these young men? We saw that TB was more in men and elderly, so we need to find ways of ensuring to get all this population and to screen them. Enhance also focus on urban TB care and prevention to address the high burden of TB in the cities and town, yeah, by the Ministry of Health, county government, and civil society partners. Then the third one, we need to expand the social protection and food subsidies to all men. How to improve community awareness of TB symptoms? We need to develop targeted messages and health education on TB to key affected population, encouraging people to seek early intervention for any symptoms of TB, as it was shown. Then we also need to expand school health program to include TB and target children as change agents to reach the young families. So those were what we had in the TB prevalence, and what some of the suggestions that came from the prevalence survey. I know we have done a lot as a TB program in different counties to ensure that we get these TB cases that were missed previously before 2015. Different innovation came out, different community targeted screening also came out so that we get these cases that we are missing. We have also challenged innovation by Global Fund on how we are able to get men who are in workplace so that we are able to screen them and also subject them to TB testing and getting them early. So the different innovation that the country is doing through support of our partners was based on the recommendation that came out from the prevalence survey. So when we come to TB programming in Kenya, I've divided this as a cascade from identification, what needs to be done, diagnosis, treatment, follow-up, outcomes, prevention, and area that we need to invest so that we can support TB programming. When we look at TB case finding and early identification of cases, this area, we look at the community-based TB case finding and facility-based TB case finding. From the prevalence survey, we saw that we are really missing cases. Patients are coming to facility, they are not being diagnosed. A percentage, a third of them, they are not being diagnosed. They are even coming more than 5 times before diagnosis is being made. We saw that patients are also, individuals are also in the community, and they are not seeking TB services and care. So how can we get these cases? So we look at it at community-based, how we can get the cases that are the community, and how we can improve case finding to find these missing cases of 40% at facility level. So when we look at community-based TB case finding, it is done through 2 ways. We have the contact tracing of all bacteriologically confirmed TB cases. And this we usually do invite the contacts of all bacteriologically confirmed to the facility to be screened and tested for TB. With early screening, if we screen them early and test them early, we are able to identify TB cases because they are close contact of those who have confirmed to be smear positive, culture positive, and we can put them on treatment. Those who screen negative and they test negative for TB, we give them TB preventive therapy. When we look at another area in community, we also do community targeted TB screening. This is very important. In cases where we find areas with high TB case finding burden, targeted community TB screening and testing at this population is very important so that we are able to get the cases as early as possible in the community and test them and also put them on treatment. So when we come to facility-based TB screening, what do we do? From the prevalence survey, we saw that patients are coming to us and we are missing the cases between 45 to 50%. And most OPD visits are usually revisit or return within the same month with similar symptoms of cough, upper respiratory, lower respiratory cases. What are we doing? Are we screening these cases for TB? This high level of revisit is an indication of low index of suspicion of TB and misdiagnosis. As it came out from the prevalence survey, we saw we are really missing cases, and this delays diagnosis and increases the transmission of TB. Lastly, on that slide, our midterm review on 2013 indicated that 1 out of every 3 health facility has treated at least 1 healthcare workers with TB. Yeah, so this shows there's an ongoing transmission of these cases at facility level. So we need to ensure we do active case finding at facility level. We need to do ICF at facility level. Yeah, we need to screen. We need to screen people who are suspected to have active TB as they come to our facility, look at them, the presumptive, and also test them for TB. So who is a presumptive case? And we see presumptive case is any person who present with symptoms or signs suggestive of TB. And this diagnosis of presumptive cases should be made by a clinician. They need to review these cases that are coming to our facilities with respiratory symptoms and illness. And this can be done in all service delivery points. We find that we are also missing mothers, antenatal mothers. We are missing them. They are coming with signs and symptoms for TB, but we are not screening them for TB. So it is very critical in all our service delivery points. We screen for TB so that we don't miss these cases and they are put on treatment as early as possible. So when we look at diagnosis in TB programming, all presumptive TB cases who have evaluated, they have been evaluated, they need to be tested for TB. And currently we have different methods which are very fast, unlike before, where we were having microscopy, where we had to subject a patient to 3 sputum. Nowadays we have a different method that you are going to see. We also need to revamp our sample referral networking to ensure that facilities without diagnostic centers, their samples are picked and sent to the referral hub. And we should not refer patient, but sample. So when we look at different diagnostic methods for TB, we have different, even before a long time ago, I know we have been using microscopy for so long to diagnose TB. We have the cultures that are there. Lead microscopy came in 2009. Then Gene Expert came in 2010 up to now. We have the new TrueNat that has come to Kenya this last month. And TrueNat is one of a good diagnostic material that usually it can test TB even in the peripheral facilities. It uses battery. It doesn't require a very big space. And also the turnaround time is very minimal, around 1 hour. We also have for our TB HIV client, we have TB lamp for clients who have disseminated HIV, and mostly they have disseminated TB. Yeah, we don't have to miss diagnosis. We have the TB lamp, which can be diagnosed on a bedside area. For our latent TB diagnosis, we have sites and pilot facilities that are using IGRA to diagnose latent TB infection, and is usually a one test done for this client to determine if they have latent TB infection, and hence they get the TB preventive therapy. When we look at the treatment for TB, the TB programming for drug-sensitive TB, all type of TB apart from TB meningitis and TB of the bone, we treat it for 6 months. 2 months of rifampicin, isoniazid, pyrazinamide, ethambutol. Continuation phase, 4 months of rifampicin and isoniazid. Then for TB meningitis and osteoarticular TB, we treat it for 1 year. 2 months RZD and 10 months of rifampicin isoniazid. It is important to note that follow-up sputum for bacteriologically confirmed cases, it is very important at 2 months, 5 months, and 6 months to determine our patient if they are cured. And currently in Nairobi, we have not yet reached that. Even at the national level, they are yet to reach the 90% target of cure rate. And for children, because children use the same regimen as adults, and I just wanted to add a slide. We are using ethambutol currently for our children. Ethambutol is the 4th drug in the intensive phase for our children, and the risk of toxicity, it was shown it is negligible if we use the recommended dose. So toxicity is usually based on the dose related and not dependent on the drug. It is usually dose related. So we are giving our children ethambutol, so it is safe in our children if we give at the correct dosing. When we look at the treatment of drug-resistant TB, currently we are using the injection-free treatment for our patients, which was introduced in 2020. For severe forms of drug resistant, that is MDR, RIF resistant, pre-XDR, and XDR, We have 2 phases of intensive phase 6 months and a continuation phase of 12 months. And these are the groups, 3 classes of the drug that we use. I'll not go much detail. We need to refer to the drug-resistant TB algorithm. We have 3 classes that we use the drugs. I know DRTB was covered a few weeks ago. And what I'll say, we use as much as possible drugs in class A and B. And if you cannot use drugs in class A and B, then it can be selected in class C. So patient follow-up, very important. We need to monitor, I've said about the smears cases. We need to monitor this group. We need to look at weight. TB, we look at the weight. Is the weight improving? Are the symptoms improving? To monitor this client. Radiological monitoring may be warrant for patients who have extensive pulmonary disease. We also need to monitor any advanced drug reaction to our patient as they come. We need to monitor ADRs. We also need to monitor adherence because this is very important. We don't want to get resistant. You need to check as they come, are they adhering to the medication? Yeah, clinical diagnosis and EPTB cases require clinical follow-up for improvement. And you also need to look at any differential diagnosis and comorbidity that this patient could be having. Very important, schedule visit at month 2, 3, 5, and 6. We need to look at smears. For those who are bacteriologically confirmed, you need to follow smears at month 2 and month 5 and month 6 for you to declare this patient that they are cured. For those who remain positive at month 2, what do we do? Patient who are smear positive at month 2, it is very important to evaluate adherence of this client. Are they taking their medication as it is required? Or other causes could be also due to delayed conversion. They could be having extensive pulmonary disease, which is taking time to convert, okay? And it is very important to request all the following drug-sensitive TB. You need to request also for first-line LPA, second-line LPA. You also need to do culture for this client who are still positive at month 2. What you need to do, you do not switch to rifampicin isoniazid. We still continue with the rifampicin isoniazid, preazinamide, ethambutol for 1 month until you get your DST result. This is very critical in case there's any resistance. You don't want to amplify the resistance by giving only 2 drugs. So we continue with the 4 drugs until you get your DST result. Then you can switch to rifampicin isoniazid. Patient who remain positive at month 5, 6, this is a patient who has failed the treatment. So you need to declare your patient as a failure. You also need to request your gene expert. You need to do your first line LPA, second line LPA, and also you need to do cultures, review your DST result, and you initiate your patient on treatment. You also need to evaluate on adherence. Are there any causes of adherence? Are there any causes of delayed conversion for these cases? Then after that, with your result, you can see how best to start your patient. And these are some of the factors that lead to positive, a patient who has not converted. And there are many different factors. Could be a very extensive cavitatory disease that is delaying conversion, could be due to poor adherence of the client, could be due to underdosing of the client, malabsorption. It could also be due to HIV infection, which also take time, or chronic diarrhea. Patients who have diabetic mellitus are slow converters, so sometimes it takes time for them to convert. Also, the older age, smokers, male, and also it could be due to delayed consultation and high bacillary load that is there, so it's taking time to convert. So what do you do in case of an interrupter? You get patients who interrupt medication while they're on follow-up. So this is divided into 2. During intensive phase, what are you supposed to do in case you get an interrupter? If they have interrupted for less than 2 weeks, what do you need to do? It is very important to perform adherence counseling to this client, address what could be the issues of interruption. Continue treatment at the point they stop, and you add the missed doses. This is in the intensive phase. So if they miss more than 2 weeks in the intensive phase, what are you supposed to do? It is important you are going to perform adherence counseling. Just know what could be the issues of drug interruption. At the same time, request for smear microscopy. If positive, that time, classify your patient as a failure. Then you restart your treatment afresh until the full course of treatment. At the same time, you take a sample for DST and culture so that you can do a follow-up. If a patient in the intensive phase, they have interrupted medication for more than 2 months, you need to assign your patient as lost to follow-up. Once they return, you put them as return after lost to follow-up, and you restart your medication afresh as you do your DST. What will you do in cases a patient interrupts treatment in the continuation phase? If they have taken their medication for 2 months, then the continuation phase, and they have interrupted treatment for less than 1 month in the continuation phase, you need to perform adherence counseling to address what could be the causes of interruption. You need to continue treatment at where they stopped their medication until the end. If they have interrupted for more than a month, you need to do for counseling, address the causes of interruption, request again microscopy. If negative, you continue and you add the missed doses. If microscopy is positive, classify as failure and restart your patient again on treatment as you perform your DST and culture for this patient and all the interrupters. If they interrupt for more than 2 months, assign them lost to follow-up. Once they come back, they are returned after lost to follow-up. You start your medication and you do your DST for this client. So on matters programming of treatment outcome, these are definitions of treatment outcome. Very important because we have issues with cured for a patient, and a patient who is cured is a patient who is a pulmonary TB cases with bacteriologically confirmed. These are the patients that either culture is positive, smear is positive, they have confirmed, they have been, the bacteria has been seen, okay, at the beginning of the treatment, and who has smear culture negative in the last month of treatment and at least 1 previous one. And this is for the drug sensitive TB cases. So you'll declare 1 person that is cured if they have follow-up sputum. 1 of the follow-up sputum together with the last, the month 6 sputum should also be negative. Treatment completed. These are the patients who started treatment. Okay, they have not shown any signs of failure, no records of maybe sputum follow-up. It has not been done, but they have not absconded treatment. They have taken their treatment throughout until the end, but you don't have your smear. And also this one, we also assign for those who have extrapulmonary TB cases. Treatment success, this is the sum of the cured and treatment complete. You get the sum, you get the treatment success rate. Patient who have treatment failed, this is a TB patient whose smear or culture is positive at the 5th month of treatment or later during the treatment. Then you say your patient has failed your treatment and died, a patient who died for any reason while on TB medication. Then we also have an outcome of move to category 4. This is a patient who is confirmed to have drug-resistant TB while they are on first-line treatment. So they cannot take the first-line medication. They have to be moved to category 4 medication. The next one is lost to follow-up. This is a patient who did not start medication or who started medication and interrupted at 2 consecutive months or more. Then you assign your patient as lost to follow-up. And not evaluated, this is a patient that an outcome has not been assigned. Either they have been transferred out or to another unit for one reason or another, and the treatment assignment is not done. Then it's very important as you're doing the TB programming, just to understand undesirable outcome that is not acceptable, that we need to work on as a team And this is a loss to follow-up, death, and transfer out. When you talk about loss to follow-up, yeah, we are supposed to have nil loss to follow-up. All patients started on medication need to be followed up until we finish medication. So it is very important as a way forward to have early identification of clinic missed appointment. Once a patient misses one clinic appointment, we need to do immediate follow-up. We don't have to wait until we have assigned them a loss to follow-up outcome. Health education is very critical. We have found that our patients don't have enough education about their disease, how long they are going to take their medication, the side effect of the drugs, the misconceptions that are there, the checkup that they need to do, the follow-up sputum. So as they start the medication, we need to give them all the details that they require. As they come, we need to talk the importance of adherence so that they are not lost to follow-up. Counseling is very important for our key population, like people who inject drugs, street families, or even other clients who have other comorbidities. You need extra support. We need to give them extra support. Death. Why do patients die while still on TB treatment? I know sometimes it is inevitable. Sometimes it could be because of delayed diagnosis, okay? We need to ensure that we get TB cases as early as possible by doing active case finding for a HIV patient with advanced HIV disease. Some of them just come in with the TB that is diagnosed very late and it kills them. So we need to ensure we do early identification and diagnosis of TB. We need to look at mortality audit, what could have happened to this patient while still on TB medication. The patients that have other comorbidities, we need to support and manage them accordingly so that we don't say our patient died of TB. So it's a whole system of ensuring that we reduce the death rate, and this is towards ending TB in 2035. The transfer out of our patient, very important. This is not a good outcome. It's not a desirable outcome. We need to ensure once you transfer your patient, proper documentation. I know election is coming. Most of our clients will be going away, will be going to vote. We need to have good documentation so that we don't lose our patient. They don't become lost to follow-up. The referring facility, we need to have proper linkage to where they are going, and we need to follow them up so that we have a good outcome. So these are the three key and desirable outcomes that we need to ensure that we reduce the minimum. As Kenya, we are not having a good outcome for loss to follow-up. Our death rate is still high, especially the time of COVID, and we need also to follow up on our transfer out. The last bit of programming is TB prevention, and TB prevention has two arms. We have TB infection prevention and control. And this is very critical because our TB patient, I just wanted to show, our TB patient visit all the areas in our facility, be it reception, be it the lab, be it the referral clinic, be it the maternity, be it the general ward. So infection prevention in all service delivery points I know this is well known to most of us, environmental control and personal protection control. And all this cannot work if we don't do administrative well. Are we triaging our patients as they come? Those coffers as they come, are we doing fast tracking? Are we having a place for them to collect sputum? Even us as healthcare workers, are we doing biannual screening of TB to ensure that these things are well done? Are we, when we are doing assignment of the room, are we relooking at how the room is? So these are all things that we need to look at to ensure that we have infection prevention and control. And I'm happy during COVID, I know most of these things have been implemented across most of the facilities. So these are some of the IPC measures for TB. Issues of cough etiquette, how our patient coughing as they come to the facility. Are we doing fast tracking? Then we have the environmental control, with the UVGI light for areas that are highly infectious. The room that we are sitting, how is the airflow in our facility, and the personal protection, the mask that we are having. Another preventive area is TB preventive therapy that we are having, and we have extended to the population around. And the risk of latent TB infection, these are the expanded population that you are given TPT. And it's very important to understand our children contact are high, up to 3 times more at risk of getting TB. Close contact, we have seen close contact, they have even higher risk, up to 46 times of getting TB disease. So they are eligible for TB preventive therapy. For HIV patients that are infected with HIV, you can see the risk is even higher. And I know we are also giving our clients who are HIV positive, we are giving them TB preventive therapy. We have also expanded to those who are on immunosuppression or organ transplant because their immunity is very low. They are supposed to get TB preventive therapy. So this is very critical, and we need to ensure this population are given preventive therapy once screened for TB and they don't have TB. And these are the options that we have for TB preventive therapy. We have 6 months still of isoniazid preventive therapy for those who cannot use other methods. Then for our children less than 15 years, we have our 3 months of rifampicin isoniazid. Then we have the 3-HP that is also new, rifampicin and isoniazid given weekly for 3 months. And all these depend on a patient eligibility. A patient who cannot use this, they have now an option to use different. And our children, we have reduced even the treatment to 3 months. So my last slide on this is areas of investment. When you look at all this cascade of TB programming, and also when you look at the prevalence survey, we need to increase access to diagnosis. This is very important. We need to support sample networking and also issues of waiver for most vulnerable, especially chest X-ray, because it was shown it is a very important tool for screening. On issues of treatment, we need to support our clients to ensure that they finish their medication. Issues of adherence, sending clinic reminders so that we don't have loss to follow-up, very important. We need to re-engage patients who interrupt medication as early as possible, okay? And also support clinical reviews of the complex drug-resistant TB patient. On matters prevention, we need to invest on infection prevention effort, very important. We need to train, we need to engage the cough monitors at the triaging so that all patients don't queue in one area, and we need to scale up TB preventive therapy. You have seen the importance of it, and support our clients throughout treatment. And matters of data for decision making, we need to have regular TB data review meetings to look at our data and see how best we can improve. Where areas that we are not doing very well, how can we manage those transfer out? How can we manage the loss to follow up as early as possible so that we can have a better outcome? Thank you. I think that was my last slide. Dr. Tabi?
Thank you so much, Wendy, for that informative and well-articulated presentation. Really appreciate that. I'll just do a short summary of some of the key things that you have alluded to. One is that the survey showed us that we have more TB than previously thought. WHO had put it at 233, and we realized it was 426 per 100,000 population. You also noted that 83% of TB cases were actually HIV negative, and more men than women are suffering from TB. That is 109 males per 100,000 people. More TB was discovered in the urban centers in relation to the rural areas. And as a whole, we are missing about 40% of the TB cases. And also that GeneXpert is more reliable and efficient in diagnosing TB. Thank you so much for that presentation. Now I'm going to go through the questions. We have quite a number.
Tabi, you're picking, or I'm opening the dialogue, or?
Kindly go ahead.
Okay, thank you very much. I'm opening the Q&A dialogue, and I'm just perusing to see the questions that are there. Phyllis Boy, good presentation. Kindly, can you share with us strategies to bring and focus the men to seek more care and be diagnosed for TB for further prevention? I think he's talking about how can we get men at community to be coming to facility to be diagnosed with TB. Okay. Any finding on adherence to TB medication in the survey? Okay. Adherence. Okay. In most of facilities are lacking pyridoxine. How can we get some to our facility like Isumu, please? Okay, let me answer the first as I go down. How can we get men to come? Because the survey showed that men are more affected by TB and they were not coming. And I just want to say this, through support of Global Fund, we have been having different innovation in different counties, how to get these men to be screened for TB. And I'll give just an example. I know there was a Kick TB project that came through AMREF with support from Global Fund. And most of these strategies were targeting men. Like in Nairobi, we had one at the workplace. How can we screen men at the workplace using their phone? And this was done in the industries that we have in Nairobi. It was done for 2 years. We had the one that was looking at men, the long truck drivers in Mombasa that was screening the men who are also driving the trucks. Then we had also another one that looked at we have another one that looked at also TB in the police station. So there are different innovation on ensuring that we get these men at the workplace through support of the Global Fund. Although it is not enough, we need other innovation on how best can we get our men to be screened for TB. Targeted TB screening, it's also happening based on the funding that we are getting through our partners. Where we get high TB cases, we tend to do targeted TB screening, especially even during COVID. I think that was the strategy that we used to ensure that we don't miss TB cases. Matters of adherence and the survey only looked at the cases, prevalence survey of TB. So it didn't look at the adherence per se. It looked at what is our prevalence as Kenya for that. Matters of pyridoxine, I know we have on and off stock that are coming to us. But one thing I can say, the good thing with pyridoxine is not expensive. It is at least, I think, a 5 bob. I know these are the things that we get from KEMSA. Sometimes they come in bulky. Sometimes they don't come. We have stock out. Then they come again. So it's all an issue of ordering. But I'm hoping that this can be sorted soon. Okay, not a question. My chat disabled. Okay, okay.
Mweni, allow me to pose a question to Professor Lisa.
Please, yes.
Yeah, Professor Lisa, kindly respond to this question that is asking, diagnosis in children is a challenge. What's the most advisable method? Is TB LAM advisable? Professor, kindly.
Okay, yeah, thank you. And thanks, Elizabeth, for a really, really nice presentation. Yeah, so diagnosis in children, especially the younger child, is largely a clinical diagnosis. The reason being that if you know the pathophysiology of TB in primary TB in children, it tends to be in the hilar lymph nodes largely, and only when they really have advanced disease might you find it spreading into extensively enough into the lung parenchyma. And secondly, they just need very few bacilli to make them extremely sick because their immune system is immature. So you might find that a child looks like they have severe TB. but it's possibacillary. And when you take your samples, if it's deep lung sputum samples, there's very few bacilli there and below the limit of detection of your various tests when you're looking at sputum. This is why it's we tend to find our sputum positivity from children in general to be less than 15%, even though they actually have TB. So the question is, what was the question? How do you, LAM, the role of LAM, urinary LAM. So urinary LAM detects mycobacterial antigen in urine. And usually from studies that I've been involved in, where we assessed urinary LAM against many different specimens and different tests, we found that it's in children who have more disseminated forms, the more advanced TB, and the children who are very severely immunosuppressed, that is HIV with very low CD4 counts, those are the group of children where we tended to identify the LAM, the urinary LAM test had a higher sensitivity. And if you think pathophysiologically, these kids are the ones who have they have advanced TB, so they're more likely to have bacteremic dissemination in the bloodstream, and therefore they're likely then to have bacilli seeding the kidney and antigen leaking, pouring out into the urine, and therefore you detect it in the urine. So in a nutshell, LAM has a better sensitivity if you have a very immune suppressed child who looks like they have miliary or disseminated disease. It's not just HIV. We were doing that study in HIV children, but I imagine that the same pathophysiologic reasoning could apply to other patients who have advanced or disseminated TB. Actually, even from the LAM research, from other papers, they find that those who have more disseminated, more advanced disease are the ones who tend to be LAM positive. So I think it's basically you're likely to have TB antigen in the blood and possibly TB bacteremia and involvement of the kidney. Yeah, so in a nutshell, that's where LAM, but when it's positive, it's really helpful. Thank you.
Thank you so much, Professor Bimbo, for that answer. We'll request Professor Alwoch to answer the next question. There's someone who's asking, in many occasions, you find that patients who have been managed on TB disease tend to have chest pain, even after completion of the course of treatment. How can this occurrence be combated? Professor Alwoch, kindly.
You need to unmute him. I hope you'll be able to unmute him because he's not in the panelist, therefore he cannot unmute himself.
Yeah, before I do that, thank you so much, Prof. Let me go to another question that Mweni can help us address. How do we manage TB clients who get cured and then get relapses for as many times as 5 times? I hope I've gotten the question right. Mweni, kindly.
Thank you, Tabitha. The relapses, it depends on the extensive of the disease. We have had this before. Yeah, it is very important. Sometimes you have a patient with many cavities in the lungs, which is a very, very difficult scenario. Once they come, you treat them. Once they come, another cavity has opened. Yeah. So I remember we had one drug-resistant TB who had a very massive cavitation on the lungs. We treated at month 10, the patient smears turned to be positive. Yeah, so it's very critical, as you said, a normal relapse patient, they need to come back, and I think my seniors can also assist me on this. We need to do our cultures to look at it. Okay, sometimes we'll find that this patient come back, The cultures are still sensitive to the first-line drugs. You put them on the first-line drugs, they cure, they come again. So in severe cavitatory disease, this is also an issue that we have also been seeing. And I know sometimes they say surgery, but I don't know if we can do surgery in Kenya. Maybe my senior colleagues can assist Tabitha in case of severe cavitatory disease, what we are doing, because we are getting cases that are coming many times because of severe extensive TB disease in the lungs.
Thank you so much, Manny, for that. Maybe Professor Wanyoro would like to chip in.
Well, thank you. Maybe I can only chip in on TB and pregnancy, and especially in area of breastfeeding, because many people have had issues when women are diagnosed with TB and they are breastfeeding. So what we know is that one, of course, unless the patient has active TB, we would want the mother to continue breastfeeding that baby as if we have already started the patient on anti-TB management, because we know that seroconverting from a positive smear to a negative smear does not take long. So we don't want to interrupt that patient. But for those patients that we have, or maybe we are suspecting that there is either resistance or to medication, or the patient has just been diagnosed and they have a small baby, then the mother can do express breast milk until the patient has been started on medication, and then we can still continue with breastfeeding. Thank you.
Esther. The next question is to Mweni. There's a question asking, kindly make reference to the Kenya TB surveys of 1959, 1969, and 1979 in Kirinyaga District Cough Survey.
It's not a question, it's a comment by Dr. Alwatch, who is
okay.
one of the pioneers of managing TB in Kenya. And he was in charge of the National TB program for many years. In fact, one of the pioneers who set up the National TB program. So I think he may not be able to unmute himself, but he's telling us of the surveys that they did when he was in office in those years.
Thank you, Prof, for that. Someone is going to unmute him and allow him to share. Thank you so much. So move on to the next question. And this will go to Mweni. There's a question asking, good afternoon, very good and informative presentation. For the TrueNut test, is it available in identified private health facilities? How sensitive is it? And from which facilities is it readily available, since Gene Expert cartridges are currently out of stock?
Thank you, Tabitha. Have I opened a can of worms? I know we're having the new tools that were launched 2 weeks ago. And I think, yeah, it was launched 2 weeks ago, where we have the TrueNut, that few of them came to 8 counties. They're still doing distribution to the periphery. You know, TrueNut is just a small diagnostic tool, which can even stay at a facility without power, because it is battery charged. It can even do an outreach program. So it was coming to support smaller peripheral facilities. And I know 8 machines were coming. I'm yet to know exactly, they were being distributed to 8 counties in Kenya, where there are issues based on different population. Nairobi, I know they were looking at informal settlement. There was an area that were looking at the mobile population. How can they ensure that these machines reaching down on the ground. So there are not very many machines that came in the TrueNut, but I know the program is in the process of bringing other tools apart from GeneXpert. I know we are also having TB Lamp that has been distributed. I know training is ongoing to our lab team to ensure that they know what is supposed to be done on the new tools that have been introduced by the National TB Program. One good thing with TrueNut, it takes an hour to diagnose TB, MTB, but you also have to take another hour in case it is positive, diagnose resistant for rifampicin. So currently, right now, I cannot say where they are, but I know they are being distributed in 8 counties in Kenya. There were a few machines. Not all counties are going to get the machine and later on. Yeah, I hope I've answered that.
Thank you, Mweni.
Sorry, Pat, when you can also educate people on the type of specimen, the quantity, the time, issues about the practical aspects of the specimen now that...
okay. Currently, we are using sputum. Currently, I know the one that they have approved is sputum, and it's minimal, around 2 mils. What happens, the same sample, for you to, it diagnoses MTB and RIF resistant, and there's a process. There are different, toolkits that they use. Once they process the MTB and the person is diagnosed to have TB, they take another sample and subject it to a PCR for RIF resistant. So it's just the normal sample we use for our GeneXpert. But first, what TrueNut does, it will test for TB. If it is positive, then the sample is subjected to resistant. So it's not like the GeneXpert. I know GeneXpert, they are doing the same. Once you get a TB, you are able to detect if the client has a resistant or not using the same cartridge. But for TrueNut, I know you have to process one first. Once it is positive, then it is subjected to resistance for RIF resistant. Yeah, so currently they are using sputum, and 2 mils are enough for this test. It takes an hour to diagnose all the process because they have to put the samples to settle. For you to detect MTB, it will take an hour. If it is positive, for the other sample to be subjected to a PCR for RIF resistant, it takes another hour. So diagnosis for TB, it's an hour. For another resistant, it's also another hour. I hope I've answered, Dr.
Yes, you have, Mweni. Thank you so much. Part B of that question was, how does TrueNut compare to Expert in terms of accuracy?
It's almost similar, above 80. I need to confirm that, but I know it's above. Sensitivity is above 80. It's above 88. I need to confirm that from the slide, but it's almost similar. I know the lower one is TB Lamp. The Lamp is the one at 75 sensitivity, but TrueNut is almost similar like GeneXpert sensitivity, around 84, 85. But I need to confirm that. Yes, thank you.
Thank you so much for that. Professor Aluoch, kindly address this question. Someone was asking, many occasions patients who have been managed on TB disease tend to have chest pain after completion of the course of treatment. How can this be combated? And also kindly make some remarks on the surveys that you had mentioned. Karibu, Professor.
Thank you very much for giving this chance to participate. Let me also first thank the speaker for excellent presentation. In fact, that is what really interested me when I saw the result of the survey. And I looked at the surveys we did in 69 and 79. And if you look at them, the record's still available there in the Ministry of Health. unless somebody has probably discarded them. There's very little difference. Despite the increase in the number of health personnel involved in needs of health and TB work and education of the public, I'm still seeing that there's a so-called the various the gaps between the incidence and the diagnosis and the presentation of the cases of TB is still not very different. But the question of chest pain, most of it is psychological. Most people who have had TB, I don't think there's much medical reason to have the TB. The other thing I wanted to talk is about the use of urine alarm. The urine alarm has been like maybe a change in fashion. That time when it's completely regarded as pretty useless in TB, whether HIV or not HIV. That's how we say this. But I don't think it's one we can rely on under the circumstances. The other thing which most people don't want, most of the doctors, is that the gene expert probably should not be used in people who have had TB treatment before. But I see many cases of TB for relapse or failure, and particularly in HIV cases where the patient may be treated for TB, but there's not much clinical change in and radiological change. And radiology says TB to be ruled out, and the clinician often orders gene expert. I don't think this is one of the recommendations, but most people don't seem to take it. But the surveys are interesting, and I'm glad to be able to be part of this.
Thank you, Professor, for those comments. When you kindly comment on TB preventive therapy uptake, specifically on non-HIV positive patients and healthcare workers.
Sorry, I'm just moving up and down. TB preventive therapy, I want to start, there was a question on, are we giving, why did we move isoniazid and now we are giving TPT? There was an earlier question and I want just to allude, we added other drugs on TB preventive therapy. Apart from isoniazid, we're having for our children rifampicin and isoniazid for 3 months. And we are having 3-HP, rifampicin, and isoniazid. So we have not removed isoniazid. We have just added other drugs. So that's why we call it TB preventive therapy. It's not isoniazid alone, but it has included other drugs that are used to prevent TB. Yes, for healthcare workers, TPT, I'll just comment in Nairobi because this is where I work. Currently, we are at 30% of TPT among the healthcare workers. Among the household contact, we are at 71%. So not all contact we have been able to reach to give them TB preventive therapy. Others are not coming, others are still having issues with the TB preventive therapy. We are still also struggling with healthcare workers, but I'm happy Nairobi was selected for the few pilots on use of IGRA that we are using one facility. We are yet to get another facility that will be doing IGRA tests. Currently, we are using Pumwani Hospital because the machine that they use, it's the ELISA machine. It's a bit complicated. I've not seen it, but I know it's a complicated test that samples have been taken. They are taken through different series. But we are there, and our healthcare worker also getting these services before giving them TPT. We are yet to get a second facility to be doing IGRA because of commodities. Yes, I saw a question of commodities. Few counties are doing this because they are using the ELISA machine. If you have the ELISA machine, kindly communicate with the county CMLC because this was the channel to support IGRA test that we are currently having. Okay, back to you, Tabi.
Thank you so much for that. Professor Bimbo, kindly address this question. What are some of the strategies that we can use to improve active case finding in pediatrics?
So basically you're asking to diagnose in kids. So basically, kids, it's your clinical diagnosis. You take your good history, you have your suggestive symptoms, and in our national pediatric TB guidelines, and even in the job aid, if you can remember the four suggestive things that you look for in a child: persistent cough, or in the younger one, there may be no cough, it may be persistent, just breathing fast, or wheeze, because they often the young ones may just have lymph nodes compressing their airways, but they're not coughing. So persistent respiratory symptom, more than 2 weeks. Number 2, persistent fever, more than 2 weeks. In the younger children, they don't have night sweats, but the older ones and teenagers may have these drenching night sweats. So number 2 is persisting fever. Number 3 is your poor weight gain. It's easier to pick in the young ones because they are supposed to gain weight fast, and they go to be weighed. So look at their growth chart. In the older ones, you have to ask that question carefully. Are your clothes becoming very loose, etc.? Because older children, they never go to be weighed. People don't have weighing scales in their home. So you have to ask strategic questions. So poor weight gain or weight loss, that's number 3. And number 4 is lethargy. Lethargy in a young child is they just don't have energy. They're not playing outside the way they used to. And a young infant, it may manifest in they're just delayed in developing their motor milestones. They should be sitting by this age. They're not sitting. They should be standing and walking. They can, but so they're lethargy, and all of these lasting symptoms generally lingering on for more than 2 weeks. So those are your symptoms. Classic. History contact, often you may find if it's there, it's very, very helpful. So contact, don't just ask in the home, ask if this child goes to a nearby daycare, or whether they've been in a hospital setting, whether they've been sitting on a queue somewhere or admitted recently. That hospital exposure is equal to a high likelihood of exposure to TB because of how much TB we have in our hospitals, and we have poor infection prevention control. So contact history is either in the home, in a neighbor, or in the being exposed in hospital setting. So you have to use your history, contact, examination, any abnormal respiratory finding. Again, it presents in different ways. So if it's wheezing, you hear, that's tick. If you hear has a high respiratory rate, tick. In the early stages, the only sign you might see is that high respiratory rate. And then as it progresses, they may have wheezing, they may have consolidation, etc. So abnormal respiratory examination. Then do a chest X-ray. Chest X-ray, and this is well described from various publications. Chest X-ray can, in 80 to above 80% of the children who have a chest pathology, it will be detected on the chest X-ray. So any kind of abnormality on chest X-ray. And in a young child, do a lateral view chest X-ray if you can. We now have computer-aided diagnostic for TB. That is the digital X-ray, which has a computerized way of showing red hotspots. It takes the X-ray, and where it sees abnormal pathology, it shows red hotspots, and it will then interpret the X-ray and say, this child's X-ray is suggestive of TB. So that's chest X-ray is so key. For diagnosis in children, 80% of them, it's going to be the one that helps you. Now, microbiologic diagnosis, try as much as you can But the reality is only in 85% of them, it will be negative despite them having TB. So you must know how to interpret that lab test. 15%, and this is from our national TB data. You know, we've done national mid surveys, and we've looked at the lab reports, and only between 13 and 15% of the sputums or the gene expert tests done on children who are suspected to have TB are positive. Only 15%. But 85% we make the diagnosis on your history exam and chest x-ray. So you can look for your microbiology, try and get your sputum if you can, try and do your urinary lamb, but only just know how to interpret. If it is negative, please do not say this is, I thought this child has TB, I think they look like TB, but now the test is negative, what is it? Please, that has confused and delayed decisions on treatment. So remember, it's your microbiology confirmation is icing on the top of the cake for children. Make your decision early enough. But in the older children, when you have an X-ray that shows extensive lung parenchymal pathology, the older child and the teenager, that's the child where your sputum might be more likely to be positive by whatever assay that you use, whether it's LAM or TrueNat, etc. But the younger children, you're not going to get it. You're not going to get the bacilli. It's possibly below the limit of detection. Yeah, even the expert ultra, we had all sorts of hopes that it's going to help us to pick it up in children, but imagine that the evidence that's emerging is that it only picks up maybe an incremental 10%. So it still misses most of them. So it's a clinical diagnosis and a high index of suspicion. If you're not sure, give this child 1 week of antibiotics, see them a week later, and if their pneumonia or their respiratory symptoms are not better, their fever is persisting, and it's not resolving on TTB therapy, on first-line antibiotic therapy, make your decision at that time. So not that this is likely to be TB, and give them the benefit of TB treatment. I must really stress that I feel that nowadays, I want to use the term that making a decision for TB in children is urgent. It's an emergency. In the young children under 5 years, they progress to very severe forms of TB fairly rapidly over weeks, and they die. And if you delay waiting for an expert or waiting for a lab, to make a decision, the poor child ends up with TB meningitis, mental retardation, and that's a burden. That's a terrible place to be when they could have been diagnosed and treated early when they first came a month ago. So make your decision earlier. It is fairly urgent with children. They're not like adults, where an adult you might delay by a month, but the consequences are not as severe as in a young child. Thank you for giving me the opportunity to speak to that.
Thank you so much, Professor Bimbo, for that comprehensive answer. Last question goes to Mweni. Kindly comment on CHVs at the community level in terms of management of TB cases, as well as continuous capacity building for healthcare workers. Mweni, kindly.
Thank you, Daktari, for this. We are using our CHV at community level, and they are doing a lot of contact tracing for bacteriologically confirmed TB cases. They are also assisting us in defaulter tracing and loss to follow-up through support of Global Fund. And during community TB outreaches, they are also assisting in sample referral to our diagnostic hub. So yes, CHV really plays a very key role in TB diagnosis through inviting and also picking sample at community level to bring at facility level. And also those who turn out to be defaulters, they are able to trace them at their homes through support of Global Fund. Thank you, Tabitha.
Thank you, Mweni.
Thank you so much, Mweni. There's one more last question, which goes to Professor Aluoch. Kindly comment on the earlier practice days until now. Are there similar Perhaps do we need to use a different lens? Any suggested approaches from your experience, considering we are discussing a span of medical research that could be there decades or so? What I'm getting from this question is
first, for me, I can't follow you. Just go slowly. I'm getting old and deaf. Just go slowly.
Apologies, Professor. Let me repeat the question.
Yeah.
Someone is asking you to kindly give insights comparing the earlier practice and now. What do you think that we should do? Is there a different lens that you can suggest that we use going forward? Any suggested approaches from your experience in regards to managing TB? Thank you.
Most of my research was based on chemotherapy of TB. As you know, that's what we're doing the TB Investigation Center. So that has been most of my interest over the years. It's so sad that the result, the improvement in TB therapy has not changed much for more than 150 years. In fact, the short course chemotherapy that most of you in Romania was actually, this is one of the 3 centers in the world that developed the first short course chemotherapy, which is still used up to now, nearly 50 years on. Nothing really has been established to be used on a wider scale. They're having 3 months treatment, 4 months treatment, or all this treatment of resistant cases. But treatment of drug-sensitive cases, there's been very little improvement on a large scale. And I have no idea why the research has been so slow in improving. When we developed this short course chemotherapy in East Africa, it looked like that we are going, within a few years, we'd probably go to 3 months chemotherapy. So the problem is now to treat short course, get short course chemotherapy. There's a lot of work going on drug research, but it's still too slow. And the longer you treatment, the higher chances of getting all this drug resistance because of poor compliance. This is what's causing the problem. That's, I don't know, you young people will have to tell us to work on use genetics or use artificial intelligence to get better drugs and get, as we've done, a COVID vaccine within 6 months. So you can get the use of artificial intelligence to improve this. I know, for example, in HIV now, the route to cure will really depend on nanotechnology, because all these other vaccines and things are failing. Maybe you need to use nanotechnology in TB treatment. It's already been tried, and I think it may give some insight into shorter term cure for tuberculosis. When it comes to the diagnosis, that is another area which I'm not, was not interested in much. Maybe background pathologists would do better than that. Thank you.
Thank you, Professor, for those insights. I would like to take this opportunity to thank Mweni and the panelists for that informative session. Thank you, everyone, for making time to log in. I trust that we are now better placed in diagnosing and management of TB. I wish you all a good afternoon. Thank you.
Thank you. Thank you for organizing this really important webinar.
Thank you.